Hi everyone, today we're going to be talking about groin hernia anatomy. To start off, let's talk about some learning objectives for today. First is to define hernias and its distinct classifications. Second is to describe relevant abdominal wall, inguinal, and femoral anatomy. Third is to use mnemonics as strategies to remember key anatomic features. And fourth is to understand clinical relevance of hernia in the context of patient care and application of anatomy for surgical management. So first, let's talk about what is a hernia. As you can see here in this diagram, a hernia is a protrusion of a whole or part of an organ through the body wall that normally contains it. Most hernias are abdominal wall hernias and are typically classified by its location or etiology. Abdominal hernias, or also called external hernias, are classified into midline or groin hernias. The most frequent types of midline hernias are epigastric and umbilical hernias, as shown in this diagram, while groin hernias can be further classified into inguinal and femoral hernias. In the video today, we'll be focusing on the groin hernias, the inguinal and femoral hernias. First, let's talk about the anatomy of the abdominal wall and its relation to the wall of the inguinal canal and of the scrotum, as in the context of an inguinal hernia. The mnemonic that I like to use to explore the layer of the abdominal wall and its relationship to the wall of the inguinal canal and of the scrotum is the mnemonic ice tie. Ice represents the layer of the inguinal canal and the scrotum, while tie represents the corresponding layers in the abdominal wall. For example, the I in ice stands for the internal spermatic fascia, which is derived from the same layer as a transversalis fascia in the abdominal wall. Similarly, the C stands for cremasteric muscle, which derives from the internal oblique of the abdominal wall, and E stands for the external spermatic fascia, which is derived from the external oblique of the abdominal wall. You can see this in the diagram where you see layers of the abdominal wall being renamed as it enters the inguinal canal and forms a wall of the inguinal canal and of the scrotum. We also see some other layers of the abdominal wall in our diagram. First, we see the parietal peritoneum and then a layer of extraperitoneal fat on top of that. That is now followed by the transversalis fascia, as we've mentioned, and then the aponeurosis of the transverse abdominis muscle, then the internal oblique muscle, and the external oblique muscle. With inguinal hernias, the contents of the abdominal cavity, usually a piece of fat or sometimes a part of the small intestine, can protrude through the inguinal canal. The inguinal canal also has two openings, the internal ring, also called the deep inguinal ring, and the external ring, also called the superficial inguinal ring. As a quick recap of embryology, we know that the inguinal canal forms during development when a projection of the peritoneum, called the processus vaginalis, herniates to the abdominal body wall to allow testes in males and ovaries in females to descend from the abdomen. In males, the testes descend into the final position of the scrotum, while in females, the ovaries descend into the pelvis. When the gonads have descended completely, the processus vaginalis is obliterated, as seen in the diagram here, closing off access to the tunnel. Because testes have a longer distance to travel, the inguinal canals in males tend to be more prominent, which makes them more likely to get inguinal hernias than females. Now let's talk about inguinal hernias and their classification as either direct or indirect. First, let's get situated with some landmarks of the inguinal hernia. In our diagram here, we can see the rectus abdominis muscle midline and the inguinal ligament connecting the anterior superior iliac spine of the ilium to the pubic tubercle. We also see some vasculature, the external iliac artery and vein, as well as the inferior epigastric artery and vein deriving from it. We also see the two openings of the inguinal canal, the internal inguinal ring, which opens laterally to the inferior epigastric artery and vein, and the external inguinal ring, which opens medially to the inferior epigastric artery and vein. The location of the inguinal rings will be important as we talk about the differences between indirect and direct inguinal hernias. I also want to talk about Hesselbach's triangle or the inguinal triangle, an important region in the context of inguinal hernias. Hesselbach's triangle is bordered superior-laterally by the inferior epigastrix, medially by the rectus abdominis muscle, and inferiorly by the inguinal ligament. Its floor is made up of the transversalis fascia. Hesselbach's triangle is important because this can represent an area of weakness that a hernia might form through. So now let's talk about another mnemonic that I use all the time to distinguish between the location of the direct versus indirect inguinal hernia. The mnemonic is MDs don't lie, and you can see that the capital letters M and D go together, and the capital letters L and I go together. These letters represent the position of the hernia relative to the inferior epigastrix. For example, the direct hernia will originate medial to the inferior epigastrix, while the indirect hernia is going to originate lateral to the inferior epigastrix. We can see the difference in the location of the hernia in the diagrams outlined here. Direct inguinal hernias are acquired hernias that result from the weakening of the transversalis fascia. As we mentioned, that was a floor of the Hesselbach's triangle. As a result of the weakened abdominal wall, the abdominal contents can protrude through the Hesselbach's triangle, through the inguinal canal, and out the external inguinal ring. Since abdominal walls weaken with age, direct hernias tend to occur in the middle-aged to elderly population. These type of hernia can occur as a result of increased abdominal pressure, such as when someone's doing some heavy lifting or coughing. As a yellow arrow indicates in the diagram, the direct hernia occurs medially to the inferior epigastrix. On the other hand, indirect inguinal hernias occur when the processus vaginalis fails to close during development. Due to the congenital aspect of the indirect hernia, these types of hernia can typically occur in infants and children, but it can also be discovered in adulthood. As we can see in the diagram as highlighted by the yellow arrows, the indirect hernia enters through the internal inguinal ring, which is lateral to the inferior epigastrix. The indirect inguinal hernia then proceeds to protrude all the way through the inguinal canal and out the external inguinal ring. Now let's talk about femoral hernias, a relatively rare type of hernia. Here we have another mnemonic that helps me remember the contents of the femoral triangle, which is bordered by the sartorius muscle, the adductor longus muscle, and the inguinal ligament. The mnemonic I like to use is called navel, and navel stands for the femoral nerve, artery, vein, empty space, and the lymphatics. These structures are going from lateral to medial because when you point to your navel, you're pointing from laterally to medially. Just a clinical pearl, the mid-inguinal point can be used as a surface marking for the femoral artery. Femoral hernias occur when abdominal contents passes through the femoral canal, also the E-space of navel. Unlike inguinal hernias, femoral hernias are more likely to happen in women than in men. Femoral hernias can be very difficult to diagnose on physical exam, and they are more dangerous because of the higher likelihood of presentation with strangulation because of the narrow neck of the femoral canal. Now that we know a little bit more about the anatomy of groin hernias, let's talk about some useful clinical correlations. For symptoms, small hernias can be completely asymptomatic, but larger hernias can be painful with a palpable bulge. Incarcerated hernias can occur when the contents can't be reduced back into the abdomen, and they can present as red, swollen, painful, and have symptoms of bowel obstruction, such as nausea, vomiting, and fever. Strangulation of the hernia can occur when the decreased venous outflow can cause so much edema and swelling that the arterial blood flow to the hernia sac is also cut off. Patients with strangulated hernia can have peritoneal signs, such as a rigid abdomen, rebound tenderness, and guarding. In most cases, diagnosis of an inguinal or femoral hernia can be made based on a good history and physical exam without the need for further studies. However, diagnosis may be more difficult in women or patients with obesity, and additional evaluation may be necessary. When diagnosis is not apparent, imaging can help. Imaging can differentiate inguinal from femoral hernias and also distinguish hernia from other clinical entities and complications. Groin ultrasounds are accurate, non-invasive, and inexpensive and can be used as first-line imaging for the diagnosis of hernias. Other modalities such as CT or MRI can be useful under specific circumstances, such as patients who are presenting with features of bowel obstruction. The definitive treatment for hernias, regardless of type, is surgery. However, the timing for your surgery might depend on what type of hernia you're presenting with. Patients with reducible hernias can undergo elective surgeries. Patients with incarcerated hernias should undergo urgent surgeries, and patients with strangulated hernias should undergo emergent surgery. A surgeon may elect to go open or laparoscopic in surgical repair. Open surgery is preferred in patients with prior laparoscopic repair, complicated hernias, and patients with ascites. Laparoscopic surgery is preferred in unilateral femoral hernias and bilateral hernias for ease of access. A surgeon may or may not decide to use different types of mesh in their repairs as well. Well, that concludes our lesson today on groin hernia anatomy. I hope you find these mnemonics useful as you advance in your clinical training. Thank you.